In this video, we will talk about spinal cord compression. We will define a spinal cord compression, we will talk about the etiology, diagnosis, and management. Spinal cord compression is the compression of the thecal sac by tumor in the epidural space. 2.5% of patients who die from cancer will suffer from it, and it is most common in metastatic disease. It presents most commonly in the thoracic spine, which represents 60% of cases, followed by the lumbosacral spine, representing 25% of cases, and the cervical spine, representing 15% of cases. It will also present in multiple sites in up to 35% of patients. The most common malignancies in which spinal cord compression occurs are breast, lung, and prostate cancer, accounting for 15 to 20% of cases. Clinical suspicion and diagnosis are the most important, since early recognition is key to preserving neurological function. Back or neck pain are often the first sign and occurs in 95% of cases. Red flags if there is spinal cord compression include upper motor neuron findings, such as increased muscle tone and increased deep tendon reflexes. If there is cauda equina, we will have lower motor neuron findings, such as decreased muscle tone and decreased deep tendon reflexes. We will also have subtle anesthesia, leg weakness, sensory loss, urinary retention, and bowel incontinence. For diagnosis, we will require an MRI of the whole spine, and if the MRI is contraindicated or not available, we will get a CT scan or an X-ray. For the management, corticosteroids are to be started as soon as possible, since the pretreatment function is the most important prognostic factor for ambulatory outcome. We will give them dexamethasone 10 mg IV, one dose, followed by dexamethasone 4 to 8 mg PO or IV Q6 hours. We will manage pain, and we will consult spine surgical services and radiation oncology. Many patients with metastatic cancer presenting with spinal cord compression are not surgical candidates. Spine surgery will evaluate if a surgical approach is appropriate. If that is not the case, then radiation therapy will evaluate the patient to see if radiation therapy is appropriate. Following surgery and radiation therapy, we will reevaluate symptoms and determine further treatment. If the patient is not a surgical or radiation therapy candidate, we will focus on palliative medicine for symptom management, and we will consider physical medicine and rehabilitation consult for neurogenic bladder and bladder management. A surgical intervention is indicated if there is spinal instability due to fracture, subluxation, or dislocation, or if there is an acute onset of paresis or paraplegia. It is also indicated if there are neurological deficits that can be identified through physical exam or MRI. The patient prognosis has to be taken into account too. We will look for absence of metastases, presence of a solitary skeletal metastases, serum albumin, and ambulatory status. Radiation treatment is usually from 5 to 10 days. Shorter courses of radiation therapy provide short-term palliation. They are usually indicated when the patients have a short expected survival between 3 to 6 months. For example, this short course of RT could be 4 gray in 5 fractions or less. Longer courses of radiation therapy provide more durable local tumor control, and they are usually indicated in patients with more favorable prognosis. For example, it could be a treatment of 30 gray in 10 fractions. In summary, spinal cord compression is defined as a compression of the thecal sac by tumor in the epidural space. Back or neck pain are often the first sign of a spinal cord compression, and it occurs in up to 95% of cases. We will order an urgent MRI of the whole spine. The management will include steroids. This is dexamethasone 10 mg IV once, followed by dexamethasone 4 to 8 mg PO IV Q6 hours. And we will consult the spine surgical service and radiation oncology.